Welcome to Victim to Victory, the Personal Injury Playbook, the podcast to navigating the complex legal system after an injury. We bring you the expert insights and guidance you need to navigate the legal system with confidence, help you make informed decisions, and get the compensation you deserve. Don't let insurance companies take advantage of you. This podcast is designed to empower you with the knowledge you need to protect yourself and your loved ones. So sit back, relax, and let's start exploring the world of personal injury law together.
Dr. Edward Scheid is a board-certified neurosurgeon and a fellow of the American Association of Neurological Surgeons. As a specialist in reoperative spine surgery and spinal cord stimulation, Dr. Scheid has the training and experience to help those who have failed traditional spine surgery or have been deemed not suitable for traditional spine surgery. He has dedicated his career to advancing the field of spinal surgery and improving patient outcomes. Dr. Scheid, welcome to the show. How are you today?
I'm doing well. Thank you for having me.
Oh, my pleasure. It's always nice to have somebody who's an expert in the field come onto our program. So what made you decide to become a neurosurgeon? And with regard to that, give us a little bit about your background in education and how one becomes a neurosurgeon.
Well, to answer the first part of that, I knew when I was going through medical school that I wanted to do something in the surgical specialties. So over time, throughout my medical school training, I was exposed to various disciplines like heart surgery, pediatric surgery, but the thing that really got me was neurosurgery. And the reason is that you can have an immediate impact on someone's life. So if you have a patient that is in excruciating, incapacitating pain, they can see you in the office one day, you can do a surgery on them another day, and immediately afterwards, they have such tremendous pain relief. And it's that immediate impact that really caused me to gravitate towards neurosurgery.
That's great. And tell us a little bit about your background. How do you become a neurosurgeon?
Well, I'm the first physician in my family. I grew up in Pittsburgh, Pennsylvania. I went to college in Cleveland, Ohio at Carroll University, and then went to Philadelphia for my formal medical training in both medical school and residency at Thomas Jefferson University Hospital. That's the extent of my training, and just became very interested in neurosurgery during that time.
So coming from Pittsburgh, you're mandatory Steeler fan.
Oh, absolutely.
And then you had to go off to Cleveland and deal with the Browns fans, and then over to Philadelphia. So how did that work out for you at those various schools?
Well, the problem was when I was in college, that was when the Steelers were not good and the Browns were actually pretty good. So it was a rough 4 years. Fortunately, we've turned that around now.
Yeah, that's true. So how do you approach diagnosing and treating spine injuries in a way that are personalized to each patient's needs?
It's a good question. I mean, you can't just look at an MRI that a patient brings in and say, oh, there's a herniated disc, this patient needs surgery. You have to really take it as an individualized approach. And that's something I based my entire career on. You have to interview the patient, and it's important to get a very, very detailed history on that first visit. You need to understand the accident very, very well. Okay. So someone just telling you that they were hit by a car doesn't really give you all the information that you need. You need to know, well, at what speed were the cars traveling? Was the victim's car stationary? Were they seat belted? Did they go to the hospital right away? All these things become important later. So those are things that I really want to get whenever I'm interviewing the patient. And then you're going to focus a physical exam to try to see which nerve roots are being affected. So if there's a certain disc in the neck or the back that's been affected, does what they're telling you correspond with that site of injury? And then you can look at the MRI, and then you start to put the whole picture together, and coming back full circle back to the patient, come up with a plan of how to get that person better.
Now, what I was going to ask is, you'll have people go to the hospital where they do not perform an MRI, but they'll do an X-ray. Could you just explain basically what the difference between an X-ray and an MRI is?
Sure. An X-ray is the broadest stroke, kind of the basic diagnostic test and you're looking for major problems like a fracture, the X-ray really just looks at gross bony abnormalities that you might find. So like a major fracture or some kind of displaced bone, but it doesn't capture the more subtle injuries of soft tissues, and that's what an MRI is designed to do.
And what's the difference between soft tissue and hard tissue in the body?
Well, hard tissue is bone, basically. Okay, soft tissue is everything else. So you're talking about discs, nerves, ligaments, tendons, and muscles that can be and are commonly injured in these types of accidents.
So when you're talking about an X-ray, you're really just looking at the bone structure of the body in the X-rays. Is that correct?
Right, that's it. And a normal X-ray doesn't tell you that the patient hasn't suffered a serious injury.
Well, can you explain how you determine whether surgery is necessary for a spine injury, and what other treatments are available, and do you suggest before somebody does take that big step and have spinal surgery?
I truly believe that surgery should be a last resort. So, patients that get offered surgery when they see me have usually exhausted every other option that's available to them, such as, physical therapy, chiropractic manipulation, steroid injections. And if they're still in pain after a lengthy period of conservative management, then they are a surgical candidate. Now, the one caveat to that is that if a patient comes in and they have what we classify as something called a neurologic deficit, meaning they have weakness in an arm or leg, or dense numbness in an arm or leg, or bowel and bladder problems from their back or neck problems, then that pushes them into the surgical category right away.
And why is that, doctor?
Because to not intervene or to delay surgery would lead to a worse neurological outcome and permanent problem for the patient. So when you have a nerve injury, time is of the essence, and surgery in those cases should be offered sooner rather than later.
So let's say a patient comes into you and they haven't seen anybody else, and they come into you and say, all right, hello, doc, I'm having neck pain or back pain. What do you suggest? How do you create a treatment plan that is tailored to the specific needs of that individual patient?
Well, it goes back to that careful, detailed history that you're going to get from the patient. Understanding the mechanisms of injury and really understanding to the degree that they're being impaired by the issue. At that point, you're going to want to get some imaging. And if they haven't had X-rays, we do that. If they have had X-rays, we're going to order MRIs and get the patient into most likely some type of physical therapy or chiropractic program right off the bat, once we see that those images don't reveal anything that would push the patient towards surgery.
Are there any neurological tests that you do in order to determine an injury or help you determine what parts of the body are injured?
Yes, there's electromyography, or EMG, is a test that basically monitors the nerves and their connections from, say, the fingertips all the way up the arm to the cervical spinal cord. And you can get readings from electrical impulses that will tell you to what degree those nerves are injured and where they're being injured. And those tests are really valuable to us when making a determination as to how to proceed.
And doctor, when you determine that a person needs surgery as a last resort, what kind of techniques and procedures do you use in spinal surgeries? And how do you ensure the safety of the patients during the procedure?
Well, fortunately, technology has really advanced over the last 10 to 15 years in spine surgery. So we used to do things called open spine surgery, which was the only way to do it 15 years ago, where you had large incisions and you'd have to do quite extensive dissections to get down to the problem. Whereas now we treat the patient with minimally invasive approaches, meaning smaller incisions, minimal blood loss, quicker surgeries, and certainly quicker recovery times. Safety of surgery is something that I've been focused on, and my research is actually focused on that, and specifically with neuromonitoring. so that when you're doing an operation, you can be actively and in a live format monitoring the nerves in the spinal cord to ensure that whatever we're doing to fix the problem isn't causing any damage to the nerves or to the spinal cord, and makes surgery much, much safer.
In what instances would you still have to do an open surgery and maybe remove parts of either the lamina or the foramen in order to have access to the injured spinal area?
Even doing laminectomies, I do those now through minimal approaches. Okay, so it's the analogy I use, it's almost like building a ship inside of a bottle, so you're going in through a small opening, but then once you're inside, you have access to the lamina, to the spinous processes, and you have to remove bony tissue to get down to the spinal cord or to the herniated disc to fix that type of problem.
And what are the benefits of the minimally invasive surgery, other than you won't have as big of a scar, but what are some of the other benefits?
The biggest thing is the recovery. Your recovery is a lot less as far as on a time perspective. And during that recovery, you're in much, much less pain. Open back surgery, I would tell people, you have the surgery, you're going to feel like you got run over by a bus for a few days. But with the minimal surgery, no, you're going to have some incisional pain. You're going to know that you had an operation, but you're going to be able to walk around. You're going to be able to be more active and get back to yourself a lot quicker. The other advantage is that, Lawrence mentioned the skin incision and the scar of the skin, but the more important scar is the scar that occurs deep down in the tissue. Meaning if you have open back surgery, there's a lot more scarring in the muscles, and that causes a lot more stiffness and prolonged pain over time. But with the minimal approach, much less scar in the muscle, so the patients feel normal much quicker than they would have.
Now, over the course of the last decade or decade and a half or so, does the minimally invasive procedure also cut down on the risk of infection from a surgical procedure?
Absolutely. I mean, the infection is related to several factors. The skin incision size is one. The length of the surgery is number two, and number three is the amount of blood loss. And all these factors play into risk of infection. So if you can minimize those with smaller incisions, less surgical time, and much less blood loss, the incidence of infection goes way down.
Now, have you successfully treated patients who were deemed unsuitable for traditional spine surgery?
Yes.
And what would make somebody unsuitable for a traditional spine surgery, such as a fusion or an open surgery?
Well, there's two types of patients that fall into that category. Okay, the first are patients that were told by another surgeon that they're inoperable or that they don't have a treatment that could be offered to them. And sometimes I see these people and there actually are treatments that can be offered, and there are surgeries that can be done. They might be more difficult, but that's my area of expertise. That's what I do. I either am operating sometimes on people that had surgery before and maybe it didn't work and they need some other revision of that operation. That's something that I do relatively frequently. The other type of patient is someone that was told that they can't have surgery because they are inoperable, and they actually are inoperable. And I see them, and it could be because of their medical comorbidities. Maybe they have severe obesity or a heart problem or some other kind of issue that would make surgery too risky. And in those patients, we can offer them something like a spinal cord stimulator. And the spinal cord stimulator is basically like a pacemaker for your back. You're putting an implanted device with a small battery, and that device blocks the pain impulses that are coming from the area up to the brain. It allows these people.
How does it block those, doctor? That's pretty interesting. How does the spinal cord stimulator actually block the pain or the nerve impulse?
So the nerve impulses are traveling from the peripheral nerves, say in the patient's legs, up to the spinal cord, and then the spinal cord relays those pain impulses to the brain, which then the patient perceives as pain. The stimulator lies over a certain area of the spinal cord and sends out disruptive signals. So as those pain impulses come up the spine, they are disrupted and kind of the spinal cord's, for lack of a better term, fooled. And the patient will then perceive these as more of like a numb feeling or a sort of a pleasant tingling as opposed to severe pain.
You say that you sometimes and often perform surgery on people that were deemed to be unsuitable for surgery, or it's a more difficult procedure. Why has that become your niche in the industry?
It's over the years, other surgeons have sent me patients that they either didn't want to operate on or had operated on, and now there's some sort of problem that is developed. For some reason, I've taken an interest in these difficult cases. I think that I like to be somebody that can help a patient that maybe other people can't help. And, I tend to be pretty good at those types of procedures. And if I can help a patient, then I want to give them that option.
We've talked about spinal cord stimulators for people that are not surgical candidates, but what type of revision surgery would you do? Let's say somebody has a failed fusion. How do you go in and help such a person?
So anytime you do a fusion on someone's spine, it's basically you're trying to get a bone to heal or grow together. So if you, like a broken arm, you put it in a cast, okay? But sometimes the arm doesn't heal. And then if that happens, you have to take the cast off and re-break the arm and then, reset it and get it to heal again. And with spine surgery, it's pretty much the same thing. You have a fusion, you're trying to get the body then to heal across the area that needs to be fused. And occasionally the patient doesn't fuse. And in those instances, we have to come up with a strategy to basically redo that surgery. And sometimes that means going through a different approach, meaning approaching the patient through the front, through their abdomen, or through the back, and removing any hardware that was put in, putting in new hardware and re-solidifying that area.
How else have you contributed to the advancement of spinal surgery? And how does your research benefit your patients?
Well, one thing that I'm proud of is that we have analyzed patients that I had performed surgery on using a technique called motor evoked responses. And what those are is it's a special type of nerve monitoring for a particular type of lumbar fusion surgery. And we followed our patients and showed that if you do the motor response monitoring, that the safety of the procedure is much improved. And because of that paper, people all over the country are now doing surgery using the motor responses, and that hadn't been the case before our paper was published.
And where was that published, doctor?
That was published in, I believe it was the Spine Journal. It's been a few years now, so I believe it was in the Spine Journal, and it was published probably in late 2010s or 2020.
And that's had a significant impact on this community of neurosurgeons and doing spinal surgery?
Yes, it has. It really changed the way the neuromonitoring is done for these procedures.
What measures do you take to ensure that patients receive the best possible care? And how do you address their concerns and specific needs?
Well, it's always important to give your patient the opportunity to ask questions. It's unfortunately common for doctors to simply spew out a recommendation and give the patient a yes or no, do you want the operation or not? Then that really isn't the way it should be done. You have to give the patient the opportunity to ask their questions. Sometimes I even offer the patient the opportunity to come back again, because we all have been to doctors and you know how it is. You don't think of things until you go home. No one's going to be thrilled about the idea of having spine surgery, but you want the patient to at least be comfortable knowing that they fully understand what's being proposed. They understand all of the risks and they've had all their questions answered. Those are really important things. And I think, it's attention to detail. You have to be on every single detail to be a neurosurgeon, to be a successful neurospine surgeon. You have to make sure that all your T's are crossed and your I's are dotted.
Now, that's funny because I usually tell our clients, could be your patients, to please write down any questions you have, because once you get in with the doctor, you get very nervous.
Right.
Anybody who's a lay person who gets in in a room with a professional, they'll always forget something. I deal with it in my profession, where then I'll take calls, the next hour, they'll call me on their way home. And I'm sure you receive a lot of those calls either later in the day, the next day. Oh, doctor, I forgot to ask you this.
Exactly.
And so it's very important to open up those lines of communication. Can you share some examples of successful recoveries from difficult cases that you've been presented with over the years?
Sure. I mean, there's, I can think of one particular patient that was hit by a city bus. It was rear-ended. The patient fortunately was wearing a seatbelt, but the car was pushed into the guardrail and actually turned up on its side. The patient ended up with a very severe neck injury, and she had 3 herniated discs in her neck. She was having severe neck pain, radiating arm pain with numbness and tingling. And fortunately, she did not have weakness. So we, after an initial evaluation, sent her to pain management and physical therapy and gave her an opportunity to get better. But unfortunately, nothing seemed to work. And in the end, we offered her surgery, and she had a very successful cervical fusion surgery at the three discs that had been herniated. And she made a full recovery. I think last we saw her, she had about 90% pain relief of where she was preoperative. And that's one thing I wanted to bring up, that it is important for the patients to know that these injuries that they're sustaining, these are permanent injuries. And you can never get someone back to 100% of where they were before the accident.
So with that being said, if you know you can't get somebody back to be 100%, what is the goal of a neurosurgeon? Let's take that in 2 parts. Obviously, the goal, if the person is feeling that they lose use from nerve root impingement or something of a limb, I'm sure you would want to get as much use back as possible. But let's say somebody like the last person that you saw, she was in pain, but she wasn't losing function. So what is the goal then? What is it that you want to accomplish after surgery?
Well, it's about quality of life. So you want to get that person as close to 100% as you can, and at least alleviating their pain enough so that they can enjoy the basic aspects of life. That's my primary goal. And a lot of the patients I see, their pain is truly incapacitating and they have no quality of life. They can't sleep. They can't make something to eat. They can't go outside. They can't drive. And you want to just get these basic things back for these patients. And you'd be surprised, once you lose something like the ability to sleep comfortably, it's something that many people don't think about until they're in these situations. And to be able to give that back to a patient is very gratifying and important to them.
In a surgical case, how do you involve the patients and their families in the treatment process? And what can they expect with regard to support from you and your team?
We really encourage patients to bring family with them when they come in to meet with us for a surgical discussion. Many do. And when they come in, I like to personally go over the MRI with the patient so they can see exactly where their disc herniation, for example, is, where the nerve is being impinged, and then also use surgical models models of the spine to show them and help them understand exactly what we're going to be doing and what the approach is. Once that is accomplished and they've had their questions answered, they know that we have a team approach here where, there's myself, my physician assistants, my surgical coordinators. There's a whole litany of people here that are invested in this patient getting better. So there's always somebody to reach out to if there's a question or a concern.
And doctor, what is the name of your medical group and team?
It's Neurospine Plus.
And where do you have offices?
We have offices in Paramus, Edison, North Bergen, Jersey City, and Brick.
And these are all New Jersey locations, is that correct?
Yes, that's correct.
This podcast will be aired nationally, so we want to make sure we know where to find you, doctor, if somebody should need you. How many surgeries do you perform a year on average?
Approximately 250.
So how many days a week would you do surgery on a normal week?
2 to 3.
And how many surgeries would you perform in a day?
Say 2 to 3 surgeries a day.
And approximately how long would a surgical procedure take? I know it's dependent on how complex the surgery is, but an average surgery.
Anywhere from 1 to 3.5 hours.
And you do approximately 250 of those. And how long have you been doing approximately 250 surgeries a year?
Since 2006 was when I started as actually 2004 as a full-time attending.
Ladies and gentlemen that are watching today, that's one of the questions you should always ask a surgeon is how many surgeries have you performed? How often have you done this and for how long? Because every surgeon has to perform a first surgery, but you probably wouldn't want that to be done on you.
I'd agree with that.
Thank you very much for your time, doctor. It's been a pleasure. Dr. Edward Scheid, thank you.
It's been a pleasure. Thank you so much.
Thank you for tuning in to Victim to Victory, the personal injury playbook. We hope you found today's discussion insightful and helpful as you navigate the complex legal system. If you or someone you know suffered from a personal injury, don't hesitate to reach out to us at 1-800-489-0004. Our team is here to help take you from victim to victory. Remember, taking legal action after a personal injury is a critical step in protecting your rights and securing your future. So don't wait. Make the call today and let us help you fight for the compensation you deserve. We'll be back next week with more expert insights and information.
This podcast is intended for informational and educational purposes only and should not be considered legal advice. The content of this podcast is based on the laws and regulations of the United States and may not be applicable in other jurisdictions. Additionally, any information shared on this podcast is not protected by attorney-client privilege or any other type of confidentiality. Remember, this podcast is for informational and educational purposes only and should not be considered legal advice.